All right. Well, it's 8 o'clock, so we'll get this kicked off. Welcome to the MSA and our first scientific session. Please be sure to download the meeting app for easy access to the schedule, speaker information, abstracts, CME, and networking opportunities. This meeting is being recorded and it will be available on the app for the next 90 days. Please be sure to claim your CME credits directly in the app by the deadline of September 12th. Today's highlights include the Scott Woods Memorial Lecture and the William H. Harridge Memorial Lecture, amongst original scientific research and presentations. At MSA, we pride ourselves on offering a flexible meeting schedule, so you may enjoy time with your family and colleagues. Please take advantage of this afternoon's free time with a variety of activities, and recommendations can be found on the meeting app. Join us tonight for the Noni Lowry reception and dinner dance. The cocktail reception begins at 6:30, and it's on the Lakeview Terrace, which I think was the terrace we were on last night. Following this is dinner and entertainment. This year's dinner will feature a lively entertainment with dueling pianos during the meal. Every guest must have a ticket to attend. Please visit the registration desk during a break if you haven't received your tickets or registration materials and wish to join. Also, please ensure that you have signed up for a table in advance. And we'd like to recognize our bronze sponsors, BD and SpringWorks Therapeutics. Please stop by the exhibits right behind us and thank them for supporting their meeting. They've been very generous this year, and it's a huge help to the MSA to continue to put on this meeting at less of a cost for all of us. With that, we'll get started with session one. All right, the first paper entitled Impact of Kidney and Liver Transplant Following Blunt Trauma, a propensity-matched national database study, will be presented by Dr. Wolanski.
Hello, good morning. Thank you for inviting me to present at this conference. My name is Rachel Wolanski. I'm a current fourth year general surgery resident and second year research fellow at the University of South Florida in Tampa. I have no disclosures for this presentation. So transplant patients are an ever-growing population that have unique medical complexities that come along with their transplant status, the immunosuppressive regimens that they're on, and it grows every year. Every year there's more transplants that are done and adds to the ones that have already been done previously, so it's an increasing population. There have been limited studies that have looked at the outcomes of these patients when they're involved in trauma. So our objective was to look at transplant patients and see if they have differing outcomes. Specifically for this, we looked at kidney and liver transplants after blunt trauma. So we used the HCUP National Inpatient Sample years 2019 through 2021 for our study. We included adults that had blunt trauma or admitted with blunt trauma. We identified if they had a history of kidney or liver transplant, and we separated them into two different cohorts so they did not overlap. We matched them one-to-one with propensity score matching to patients who had no history of transplant, both in the kidney cohort and the liver transplant cohort. Confounders that were controlled for in the propensity score matching model included basic patient characteristics such as age, sex, race, and insurance status, hospital demographics including location, region, their teaching status, their size of the hospital, and then some comorbidities that the patients may have, including chronic kidney disease, hypertension, diabetes, dementia, alcohol abuse, and depression, which were available readily to us in the HCUP database. Our primary endpoints of interest were inpatient death, length of stay, non-home discharge, and then hospital complications such as sepsis, pneumonia, blood clots, DVT, PE, respiratory failure, renal failure, and liver failure. First, we did a univariable analysis. Again, split the cohort into two, so there's no overlap between the two kidney versus liver transplant. So this is the kidney transplant cohort. As you can see, these highlighted are the statistically significant outcomes that were in this cohort. Of note, there was no statistical difference in inpatient death or non-home discharge before matching. So this is just our raw cohort. Length of stay, although it had the same mean, it trended towards a higher interquartile range and was statistically significant. Pneumonia as well as renal failure in this population was statistically significant. This is the liver cohort univariable analysis results. And again, there's no difference in inpatient death or non-home discharge, but there was a difference in length of stay, sepsis, renal, and liver failure. So based off of these results that were statistically significant, we moved on to propensity score matching model with to see if there was still a difference after matching. So this is a table that represents the propensity score matching results. So here I've highlighted which ones remained statistically significant after propensity score matching. So the length of stay in kidneys was still significant after matching with a effect size of 0.84 days, which doesn't seem like a lot, but may approach clinical significance as well as statistical significance. The renal failure in both kidneys and livers was also significant after matching, but they were in opposite directions. So in the kidneys, there was a lower rate of renal failure, and in liver transplants, there was a higher rate of renal failure with the liver transplant group. There are several limitations to our study. The biggest one being that it is a retrospective database study, so we're limited by what is available to us in the database. Most notably, there is limited information regarding the transplant status, including the timing of their transplant, how old, how long ago the transplant was performed, what their baseline function is, creatinine, and what their immunosuppression regimen is, which would be another interesting point to see if differing immunosuppressive regimens had any impact on their outcomes as well, because the medication doses can vary. We also limited our cohort to only blunt trauma, so excluded penetrating trauma, we excluded burns as well, and limited it to different, only a handful of mechanisms within the blunt trauma group in a attempt to make it a more homogeneous population within the trauma patients. We also limited it to kidney and liver transplants, as these were the most abundant in the database, and other transplants such as heart, liver were fewer in number and statistically could not be compared. So our results may not be generalizable to the population. We also limited to only in-hospital outcomes and didn't have any information on long-term outcomes in these patients. So in conclusion, kidney and liver transplant patients did not have differing rates of mortality, non-home discharge, or infection complications after being involved in blunt trauma. The kidney transplant patients did have a slightly longer length of stay, and there were lower rates of renal failure in kidney transplant patients. However, there was slightly higher rates of renal failure in liver transplant patients. So closer to consider closer renal monitoring in these patients, but otherwise standard trauma protocols that are currently in place appear to be adequate to care for this unique population of patients. I'll take any questions.
So this paper is a candidate for Best Paper by a Surgeon in Training Award, and the discussion will be opened by Paul Wright from Michigan State Corewell Health.
Thank you, and thank you to the association for allowing me to discuss this paper, and particularly the first paper of the meeting, so that it couldn't possibly be expected to run in the 5K this morning. Dr. Wolanski and her co-authors have sought to define outcomes in a rarely studied population, the liver or kidney transplant patient to suffer traumatic injury. Indeed, there are few data available in the current literature for this group of patients, and I applaud the authors on their attempt to tackle this topic and shed some light on the outcomes of these patients. I have a few questions related mostly to your methodology, which you have a chance to describe more in your paper than what you could do this morning during your presentation. So you chose the nationwide inpatient sample as your source data. And as you pointed out, there were some limitations in that. I think most notably, the inability to discern injury severity. So as I understand it from your propensity score matching technique, a kidney transplant who got an fender bender and stayed overnight for relatively minor injuries could have been matched with a patient of similar age and comorbidities who suffered severe trauma in a motor vehicle crash. Is this true? And if so, why not opt for something like the National Trauma Data Bank, where you could get that injury severity data? Second question is regarding your matching strategy as well. You matched kidney transplant patients with chronic kidney disease patients, though presumably many of the transplanted patients had normal renal function at the time of injury. I'm not surprised to find then that your rate of renal failure was lower in your transplanted group. You elaborate more in your manuscript, but do you think that this was the right strategy? Would you consider removing that as part of the matching algorithm? And do you think that the transplanted population is akin to a chronic kidney disease patient who's not transplanted? Thank you.
Thank you for your questions. Yes, actually, to address your first question, why didn't we use the TQIP or National Trauma Database? That's actually where this project started out. And the first idea was to use TQIP and pulling the numbers with to see how many patients had a history of transplant in that database was simply not robust enough to do statistical analysis. So we pivoted to a different database to be able to continue with the statistical analysis. Ideally, yes, we would have the injury severity score be able to stratify based off of mechanism type. Unfortunately, the HCUP NIS does not have injury severity score or the ability to calculate it. The ways that we combated that was only including blunt trauma patients and only included a handful of mechanisms within the subset of blunt trauma in the HCUP database. So we only included, if they were involved in a motor vehicle incident, if they were a fall, if they were struck by something or struck against something, and I believe machinery. So we only included a handful of the mechanisms within that category. But I do wish that we could match on injury severity specifically, and that is a limitation that we have accepted. To address your second question, why did we match on CKD with patients that have had a history of transplant? We all know organs have shelf lives, and they, even if they have a history of transplant, it doesn't mean that their organ is still functioning at perfect or expected levels. Like I said, again, we are limited with their baseline renal function. We don't have that information, but someone who has had a history of transplant may unfortunately have chronic kidney disease again. And so our methodology, our thought to include that as a confounder was to pick up on those patients that, maybe they had a transplant 10 years ago and they are, falling back into that category of having chronic kidney disease, and wanted to appropriately account for that disease that they may have again.
All right, the paper is open to the floor for any questions.
This is just because Dr. Koo is going to make me squirm later, but this is a great paper, Rachel, very nicely presented. My question is, you kind of identify this day of the longer hospital stay in the folks with kidney transplants. It's a big data set, which I actually think is kind of an advantage because it smooths out some of the problems you might have because of not being able to capture injury severity. But you may not be able to answer the question. The question is, why is that day happening? You know, and is that an opportunity for operational improvement? Like in our system, which has a pretty good transplant program, it'll take a day for the transplant teams to come see the people
Mhm.
that are in the hospital. And is it sort of a provider anxiety issue where you have a trauma patient that's got a kidney in and you just want to know that it's going to be okay and you're waiting for that kind of thing? Or is it that there's actually a different pattern of recovery or injury in these patients? Nice job.
Thank you for your question. The answer is, I don't know. I made some suggestions in the manuscript, you know, maybe it was an increase in consulting teams and that just physically takes longer to complete their recommendations or even to have them see the patient. Maybe we're treating ourselves rather than treating the patient anxiety wise. I agree. But the answer is I don't know. I don't have information regarding how many consulting teams saw the patients or if the transplant team did, if you know, if there were more interventions that were done for the transplant patients. I don't know, but it is an interesting point.
All right, thank you.
Thank you.
Good morning. My name is Heather Dolman. I'm one of the moderators with the esteemed Dr. Hollowell. We didn't introduce ourselves. I'm sorry. Our next paper is about changing therapy for melanoma, presented by Dr. McCahill.
Thank you. Good morning, everyone, and thanks for the opportunity to present this work. I'm a physician at Western Michigan School of Medicine. So my title of my talk is Missed Opportunities for Neoadjuvant Immunotherapy. I'm going to try and take you on a quick tour of what's happened in the landscape of melanoma. I have no disclosures. So melanoma care is changing probably faster than any solid tumor we've seen in a long time. Traditionally, people with clinical stage 3 melanoma, which is usually in most circumstances defined as palpable lymph nodes, are traditionally managed with a lymphadenectomy. And that's typically followed by adjuvant immunotherapy over the last 10 years. Nevertheless, recurrence rates are markedly high at 30 to 40%. Animal models in 2016 were really responsible for changing the entire landscape. I challenge you to keep track of the dates I'm going over because you'll see how quickly melanoma care has changed from animal models to humans. So what they showed is that with the tumor intact, the immunotherapy worked better. There was increased and broader tumor-specific T cell activation, and it appears to hinge on macroscopic tumor being present to help prime the immune system to initiate a more profound immune response. So that was 2016 in mice. This is 2023 in human beings. New England Journal of Medicine with single agent pembrolizumab showing a marked diminishment in event-free survival. And event-free survival includes recurrence, distant metastases, and death due to melanoma. So in the world of cancer, this was the first trial I had ever seen for neoadjuvant showing superiority for survival. Typically, breast cancer or rectal cancer was always about getting a better surgery or increasing options for surgery, but not a survival difference. So this was kind of a game changer. So at the same time, the Dutch and Australians were looking at, could we do dual immunotherapy for melanoma patients with intact nodes? And the problem was toxicity. So they did a randomized trial with three different treatment arms, and the winner was ipilimumab plus nivolumab with a lower dose of ipilimumab. And in this case, compared to the 60–70% toxicity that had been demonstrated with this regimen, they got the toxicity down to 20%. And you'll note that 29 of the 30 patients were able to go on to lymphadenectomy. The surprise response was that 57% of patients had a pathologic complete response. And for those who've done esophageal, rectal, breast cancer, this is off the charts. We're used to seeing 15 to 20% pathologic complete response rates. So that led to the NADINA trial, published less than 1 year ago, New England Journal of Medicine. So 2 cycles of dual neoadjuvant immunotherapy, followed by surgery, followed by response-directed adjuvant therapy. And what I mean by that is the patients who had the pathologic complete response were able to have no further therapy. So again, an incredible benefit for patients where instead of a year of treatment, they're getting 6 weeks. And they also expanded the criteria, which is sort of the genesis of this presentation I'm going to do, is PET positive nodes were allowed as opposed to just palpable nodes or measurable based on RECIST criteria of 10 millimeters. So quickly, here's the results of the NADINA trial. And for those who are comfortable with hazard ratios, notice the hazard ratio of 0.32, i.e. a 70% reduction in death due to melanoma, recurrence due to melanoma, or metastasis due to melanoma. So simultaneously, we have a variance in imaging guidelines between Europe and the United States. For the United States, for stage 1B and 2 melanoma, and I've refreshed you on the criteria there, what's recommended at the time of diagnosis or surgical consultation is a physical exam and a sentinel node biopsy. Europe, however, recommends ultrasound of the anticipated nodal basins. And their thought there at the time when it was presented was to decrease the number of sentinel node biopsies. So this is my index patient. I have not forgotten her. She's kind of a haunting story. She presents to me with a T3B lesion of the lower extremity. And I went back this weekend and looked at what I had written on the physical exam. And I said, no palpable lymph nodes. However, exams limited to patient body habitus. I did a wide local excision and was quite embarrassed in the operating room to find a 5-centimeter lymph node. And how do I miss a 5-centimeter lymph node on physical exam was my thought. Well, her BMI was 50.8, and unlike axillary lymph nodes where you can push against the chest wall, the groin is not so easy in a very obese individual to fill a lymph node. So a quick summary of her outcomes are not so great. She had adjuvant therapy initiated promptly, but I remember her being my only patient recently that was lymphatic leak from a seroma, cellulitis, hospitalized, IR drains. Then she gets in-transit metastasis, liver metastasis, and dies 13 months after surgery. So the study hypothesis was, could some clinically node negative patients who are later identified as sentinel node positive, they may have been identifiable as clinically node positive had we used ultrasound of the nodal basins. So we looked at our institutional database, which has 358 patients over the last 4 years. And we looked at patients who underwent a sentinel lymph node biopsy and had the pathologic size of the node recorded. We divided those patients into those, which I made this term up, but macrometastasis greater than 10 millimeters or micrometastasis. And then we did comparison testing between the two. So the results are relatively short. We had 168 patients that we performed sentinel node biopsies for clinical stage 1B and 2. 31 had positive nodes, and we had a metastasis recorded for 29 of those, or 94%. A macrometastasis, this sort of the focus of my study, was identified in 20%. If you look at the differences between the two groups, the biggest thing that comes out, they're pretty similar. There was a little bit higher incidence of inguinal nodal basins, but the BMI was a mean of 42 in the group that had the missed node on physical exam. And I will note that 5 of the 6 patients had a BMI greater than 40. So what if we expanded the ultrasound criteria a little bit? I went back and looked at all my cases from positive sentinel nodes, and roughly 40% have nodes between 3.5 and 10 millimeters. And the reason I bring up the 3.5 is if you scan through the breast cancer literature, they're always doing biopsies on any node criteria. I'm not an expert on ultrasound, but 3.5 seems to be readily detectable on ultrasound and biopsy proven to be metastasis in the world of breast cancer. So in conclusion, 20% of patients with newly diagnosed but clinically node negative melanoma patients had a sentinel node metastasis that was 10 millimeters or greater. 3 of these patients these patients were more likely to be clinically obese, and 10 millimeter metastasis should be readily identifiable by ultrasound and likely confirmable as well on PET scan. Given the marked reduction in melanoma event-free survival for clinical stage 3 patients treated with neoadjuvant immunotherapy, my feeling is that the NCCN guidelines should, changes to the NCCN guidelines for initial imaging should strongly be considered. And this is our research team that contributed to all the work that went into this paper. And thank you, and I'm happy to answer any questions.
This paper will be reviewed again by Dr. Wright.
Yes,
Paul-
thank you again to the association.
Paul, remember, I'm only in R3s. So be easy.
Yeah. I'm ready to grill you, Larry. I once again thank the association. When I agreed to this, I didn't realize they would be back-to-back papers, but I thank them nonetheless. Dr. McCahill and colleagues have presented their experience with sentinel lymph node biopsy in stage 1B and 2 patients with melanoma, seeking to show that preoperative ultrasound may identify patients who could benefit from neoadjuvant immunotherapy. While the NCCN guidelines contain a footnote that ultrasound can be used in patients with an equivocal nodal exam, the guidelines are nebulous, and in general, I agree, difficult to discern who we should image and with what modality prior to surgery. So I have a few questions. I'm going to go one by one to try to make it a little bit easier for discussion. So number one is, how have these results changed your practice? Are you performing ultrasound screening in all patients? As I read your data, this would have picked up only, while it's 20% of patients who had nodal metastases, there were only 6 macromets according to your definition of the 168 patients total. So is the juice worth the squeeze as it pertains to added cost and potentially added time from diagnosis to surgery by adding ultrasound for all patients? If not for all patients, who do you select for this exam? Is it something based on pathologic features, clinical features? Would love to hear your thoughts.
Can I go over now on that
Please,
one?
yeah.
Okay, great. Just remember, I'm a little older. I don't know if I can remember 3. So yeah, this is tough. I think it needs to be prospectively studied, but for right now, if you look at your data, I look at my data, we know that the sentinel node positivity rate is markedly jumps when you start looking at 2 millimeter Breslow depth or more. So I am starting to do ultrasound. I picked up a couple people who were PET positive, and I'm having my office set up the ultrasound if someone comes in with a Breslow depth greater than 2 millimeters. So a T3, T4 patients, or maybe a high T1 with ulceration. I'm sorry, T2 with ulceration.
Yeah, and I think from personal experience, the obese patient is a potentially a great patient to use this on. So which brings me to my second question, which you pointed out a little bit here, about who do you think should perform the ultrasounds? So can this be a surgeon-directed exam in the office as an adjunct to physical exam, or would you send them to radiology? My concern with radiology exams is that the radiologist's most common recommendation is always more radiology. And so my concern would be a possible increase not only in false positive findings that could lead to a more invasive and costly workup, but also in further delays in getting to surgery.
That's a tough one. I think radiology will drag it out to a degree that's not really acceptable. So I think what I hope to do is just sort of review the literature in terms of how high the specificity is when you get maybe a 5 millimeter metastasis. To review this literature, I went all the way back to a bunch of European trials, and the deal is when they see an abnormal node in biopsy, their specificity was 100%. So if they biopsied a malignant node, their goal was to eliminate sentinel node biopsies. But our goal, I think now, with the new literature, is this marked improvement in survival for patients. So I think the goal's so high. The benefits are so high. I think you have to accept some false negatives because they can just get a sentinel node anyway. But the cost could be considerable, and the delays could be considerable as well.
Yeah, so that leads to my last question, which is it really better to identify these patients with presumably small volume metastatic disease? So let's say the 3.5 to 10 millimeter population there. Neoadjuvant immunotherapy has gained traction for improving recurrence-free survival or event-free survival, depending on how you define it, in clinically node-positive or resectable stage 4 patients who are included on the S1801 trial, but it has yet to demonstrate an overall survival benefit. So once you've identified a node that's positive by ultrasound, how do you manage that nodal basin after neoadjuvant immunotherapy? I would argue the standard of care is still complete nodal dissection versus the patient after a sentinel lymph node biopsy could potentially be spared from that full node dissection based on MSLT2 data.
You know, this is a tough one. So I think I'm carefully following the long-term results of the Prado trial. That was a trial that looked at neoadjuvant immunotherapy. People had a biopsied node and they placed a marker, and then afterwards they just removed the marker. And if they had there was 60% of the patients had a pathologic complete response, and they did not do a lymphadenectomy. It's nuanced, but that's not what they did in Nadina. But there's now 3-year data on the Prado trial, and the event-free survival in that group is extraordinary. It's 90% at 3 years. So I think the world's changing so fast, it's hard to follow the guidelines, which are often 5 and 6 years behind. So I have kind of moved ahead, and I'm doing index node biopsies now. So I hope that answers the question.
Thank you.
My overtime or general questions?
If anyone has any other questions. All right, thank you so much.
Thank you.
All right, the next paper for this session is comparing the impact of a dedicated bedside assistant on operative efficiency in robotic-assisted rectal and sigmoid surgery. This is going to be presented by Dr. Mustafa Arak from the Cleveland Clinic Foundation. And this paper is also a paper for Best Paper for Surgeon in Training Award.
Good morning. My name is Mustafa Oruç. I'm a research fellow in Cleveland Clinic at the Colorectal Surgery Department. Today, I'm going to present our results for the impact of dedicated bedside assistant in robotic colorectal surgery. Here are our disclosures. At 1998, a futuristic article suggested that robotic surgery would separate the surgeon from the patient, and a new role with increased responsibility will be required at the bedside of the patient. And the article concluded that the ultimate use of robotics remain uncertain. However, the human touch will not soon, if ever, be replaced by the robotic technology. A decade later, this vision has become a reality, and robotic surgery changed how we operate. And the bedside assistant has become an integral part of the robotic surgery. The BA is responsible for docking, instrument exchange, retraction, suction, hemostasis, and many other tasks. Their performance and communication with the console surgeon directly affect the intraoperative workflow and the efficiency. Previous studies in urology and gynecology suggested that experienced bedside assistants reduced the operation time. However, they didn't include detailed operative analysis. And also, many of them included mixed type of bedside assistants, including residents, fellows, other staff, nurse, or physician assistants. And their definition of experience is very different from one another. And also, their surgeon experience is not standardized. And most importantly, the effect of dedicated bedside assistant has not yet been studied in the colorectal surgery. For this reason, the aim of this study was to evaluate the impact of dedicated constant bedside assistant on the intraoperative efficiency in robotic colorectal surgery. For this, we designed a retrospective study and included 148 robotic colorectal surgery cases, 90 rectal, 58 sigmoid, performed by a single surgeon. In 2021 and 2022, operations were assisted by the rotating fellow and other staff surgeons. Between 2023 and 2024, all the operations were assisted by the same physician assistant with no prior experience before starting with the surgeon. We excluded emergencies, converted cases, incomplete records, and surgeries performed by the alternative bedside assistants. Our primary outcomes was the time-related metrics. Secondary outcomes included blood loss, length of hospital stay, and the complications. We collected the operation data from the Da Vinci My Intuitive app, which tracks the real-time console activity. Operation time was defined as the total skin-to-skin duration. Active console time defined as the console time with instrument movement, and the inactive console time defined as the console time without instrument movement. Non-console time included docking, undocking, specimen extraction, fascia, and skin closure. Before analyzing the effect of the bedside assistant, we have to prove that the surgeon had already passed his learning curve. For this, we included another 100 rectal cases and collected the operation data between 2013 and 2020 and performed the QSUM analysis. Basically, you can see in this graph that between 2013 and 2016, the surgeon's operation time was longer than his median base. However, starting from the 2016, the graph started to level off, and it was stable between 2016 and 2020, which means that the surgeon had already passed his learning curve and operated on his baseline. Demographics of the patients were also similar between the groups. The age, BMI, patients with prior surgery, neoadjuvant therapy, difficult cases, patients' teeth stage and location were similar between the groups. And this means that the groups were well matched, and the only difference between the groups was introduction of the bedside assistant. As for the operative metrics, you can see in here, with the bedside assistant, operation time reduced from 255 minutes to 230 minutes. And the active console time also reduced from 118 to 98 minutes. And the non-console time also reduced from 118 to 92 minutes. And the difference was also significant in the subgroup analysis, including upper rectum and the lower rectum tumors. There was also a time difference between the patient with prior surgery and technically difficult cases, but this did not reach the statistical significance. As for the sigmoid operation, there was no difference between the operation time. However, we still observed some meaningful differences. The proportion of the active time compared to total operation time increased from 37% to 42%, and the inactive console time reduced from 8% to 5%. You can see the distribution of the operation time in here. Even in rectal cases where the operation time was already reduced, non-console time, the proportion of the non-console time reduced from 48% to 44%, and the active console time increased from 44% to 48%. This means that even the total operation time did not change. We used the operation time way more efficiently with the bedside assistance. As for the secondary outcomes, there were no difference between the estimated blood loss, complication rate, length of hospital stays, and complete resection. This means that there was no trade-off between the efficiency and the safety. As a conclusion, a dedicated bedside assistant significantly improved the operative efficiency, especially in complex rectal resections. This finding supports structured assistant assignment as a scalable quality improvement target in the robotic surgery. Thank you for your listening.
Dr. Bill Shiraka will be the invited discussant for this paper.
Thank you. The authors confirm the efficiency of a dedicated team of professionals, that is anesthesia, surgeons, and surgical assistants, peri-op nursing, et cetera, to perform high-risk, technically challenging operations, such as coronary bypass, transplant operations, and so on. In this retrospective review of the role and impact of a dedicated bedside assistant, or DBA, for robotic rectum and sigmoid colon resections, I have the following queries. First, DBA in your pertains to your manuscript. It's kind of a vague and unfamiliar term, not clearly defined in the manuscript, but I think it's important for many reasons, and as you've pointed out in the study, not the least of which are hospital credentialing and liability issues, which may be related to potential surgical misadventure. If this role is critical to the successful completion of operations, it should be well defined. Apparently, the DBA in this study was a physician assistant with no formal surgical training and no prior operative experience. Since the background of the assistant can influence outcomes, how much individual education, training certification is required to replicate your study outcomes. Could a surgical technician or nurse provide the same level of assistance? Second, the DBA's precise actions and contributions to the operation were not entirely obvious. Are they scrubbed in alone or with a surgical tech or scrub nurse? Are they creating and closing port sites and or extraction sites for specimen removal? Are they inserting and handling instruments, cameras, performing anastomotic leak tests, et cetera? And in the manuscript, there was a phrase, hemostatic maneuvers, which they performed. And what specifically are these hemostatic maneuvers? Third, having the same DBA for all cases is advantageous, but at what cost? Do all clinic surgeons have their own DBA? What is the impact on surgical resident training and education? Do you sync your PTO, personal time off, or does the surgeon sync it with their DBA? Fourth, were the DBA efficiencies described also apparent during non-robotic colorectal operations, such as laparoscopic, hybrid, or even open? Lastly, what about oncologic outcomes? Any differences in circumferential resection margin, R0 resection, anastomotic leak, overall disease-free survival? I enjoyed your paper. Thank you.
Thank you for all these questions. For your first question, in the study concept, the dedicated bedside assistance means having the same bedside assistant through the whole operations. But in broader context, you can say that having an experienced team member dedicated to bedside tasks. And for your second question, although other studies suggested that nurses can also perform this kind of task, physician assistants train in a more physician manner, therefore they will be more suitable for this kind of tasks. Surgical technicians, I believe, do not have the technical background. And bedside assistants have many different educational roles, such as if you have a bedside assistant in the patient near side, this means that your fellow or the second surgeon can be at the second console. This means that more exposure for the residents. And the bedside assistants also, whenever needed, they can teach the bedside tasks more efficiently to the fellows. And the cost analysis, this is one of the limitations, and no study ever evaluated the cost of bedside the physician assistants. And I believe this is a too hard task to complete because there are many variables. The operation time reduced, there was less medication, but there were additional costs. This should be really evaluated. And as for how much experience is required, different studies suggest that different information, some of them told at least 10 cases is required for shadowing just before to having some kind of efficiency. Others suggested that 50 cases is required maybe. But the problem is there is no objective measures that telling us when a bedside assistant is experienced. Therefore, this is more easy for the surgeons because we know that when a surgeon has reached his experienced advanced level, but this still needs to be defined. And for this study, we decided to include all the cumulative cases for that kind of particular assistant, and therefore we will show the cumulative effect of his novice and his experience level. Thank you.
Couple of questions from here. Across your time period, robotic technology has advanced. Did you use the same machine for the entire study period, or were there different machines because the amount of time to set up and get the case going is different between the SI, XI, and DV5? And then you had one surgeon doing all the cases. Was there a fellow resident involved in any of these cases? I know when have the opportunity to operate by myself, typically the times are 20% lower than working with a trainee from various levels, from a PGY2 all the way to a fellow. Thanks.
First of all, isolating the effect of the site assistant has many confounders, but for this study, the room is same, the machine is same, the operation team was same, everything was similar except for the introduction of the bedside assistant, and the device was DaVinci Xi. And for your question, there was no my intuitive application whenever we used the SI version of the DaVinci application, DaVinci device. And for almost all cases, there was a fellow or resident included in the operation room, but I did not include the time they used the machine, or they did not. We don't have any information about how much time we spent for the training for them.
This is a senior author of the paper. I can just chime in there. Absolutely agree. And that's a factor that it's confounding factor that it's hard to adjust for. But throughout the study period, group 1 and group 2, with and without the bedside assistance, our practice has been similar in terms of how much we let the residents do. Of course, quantitatively, it's hard to prove that, but in generally speaking, we let the certain portions of the operation done by the fellow. Even there's different rotating fellow or resident available. But like Dr. Orich mentioned, there's a dual counsel, so they always are on the dual counsel, and they typically do certain amount of part of the operation. So I think that can be considered standard for both groups. Thank you.
First, Mike.
University of South Florida, Joe Suica. Thanks for the presentation. I just want to lead with, I agree with you. I think that a bedside assist is very important, someone who's consistent. A couple of things I wanted to ask. One was, how did you define a difficult case? Because I think that's a really nebulous metric that I think is very important in this scenario. The other thing was, I found your QSIM analysis to be sort of interesting, because usually when you look at a time change over time, it doesn't go up, it goes down. And so I was sort of confused by your QSIM analysis. And I was curious to know, did you do a QSIM analysis on both the before and the after? So what I mean by that is if you're introducing something, of course, there's going to be an upswing in change in time, right? There's going to be a learning curve for that bedside assist. I would argue that the benefit of a bedside assist is not just their familiarity with the operation, but the familiarity of your tray and what you need, more so than just what they're doing at the bedside. Because if you have all your tools, you can just keep operating. But when you have to wait for the circulator, the bedside assist, the surgical tech, whoever it is, to go and get things or not have something, you're going to kill your time. So I guess my two questions really are, what's the difficult case? And then did you do a QSIM analysis both on the before section and the after section to see what kind of learning curve is needed?
For your first question, sorry. For the QSIM analysis question, I should answer that first. For that kind of time period, yeah, it looks like it goes up, but there are many different ways to perform the QSIM analysis. Therefore, we calculated the whole cases, the 100 rectal cases median operation time, and which was, I believe, 300 cases. And this means that in the first years, the surgeon's median operative time was longer than that, and the graph started to increase. But after around 2016, the graph started to level off, which means that the surgeon's operating time was similar to the surgeon's baseline. But the graph, whenever the graph moves up, it stays in there. In order to graph to move down, the surgeon had to operate lesser than his median operation time. But we could have done that many different ways, and I believe that this was the simplest one to show that the surgeon has operated at his median baseline. And can you repeat for a second?
No, what I was essentially asking is that did you do a QSIM analysis on both of your cohorts? Because the interesting part of this, I think, would be what is the learning curve and the change in time on your QSIM analysis for your second group with your bedside assist?
I didn't do QSIM analysis because we have only 330 cases for the rectal ones and 34 cases for the sigmoid cases. I believe to understand the experience of the bedside assistant and do a QSIM analysis, I would need more data to understand to evaluate the impact. Because this would be a different study to understand whenever a bedside assistant reaches experience level, how many cases is required. This should be in another study, I believe.
But the only pushback I'll give you on that, and I'm going to leave you alone after this, I promise, is that the point of the study is to show that the bedside assist is helping times, right? And so if you're finding that in your data set, you should also be able to tell where's the learning curve for the bedside assist, even a small sample size, right?
Definitely.
I would argue with you that I think that 5 to 10 cases is enough for most bedside assists to know what do you need, what are the steps of an operation, when do you need them?
Yes.
But I don't have anything to back that up outside of experience.
Definitely, you're right.
We have time for one quick question, comment.
I love this study, but I don't agree with it. I mean, I think when I went from laparoscopic to robot for pancreas surgery, like one of the things that I was shocked by was how great the tools are. Like they're so simple. You just put them in and they work. As opposed to the laparoscopic instruments, you got to fiddle with them, assemble them. If I need something that I don't have, it takes 20 minutes for the techs to figure out how to put it together again. The robot's extraordinarily expensive,
Yes.
period. It saves you at best a half day inpatient stay a day relative to laparoscopy. That's $500, $600, $700, something like that. We need to be figuring out a way to use the machine in a way that's cost effective, not adding cost.
Yes.
And I think bedside assists have health benefit. I mean, I love people and I want to employ America, but I mean, they're expensive. People are expensive. So um, you know, what we do is we have the surge techs. We have one surge tech, a medical student and a resident at the console for Whipples. That's it. And I feel like it's good. I mean, it's getting more and more efficient. So I guess my question is, what are they doing? You know, that a tech can't do. I mean, I'm lucky I get to work with the same 2 or 3 techs every week. It's different every week, but it's always one of 3 people. Those guys are great. And they can figure out the robotic instruments better than I can. So what are these guys doing for you that you really feel like is helpful? Thanks.
Quick comment.
Yeah, quick comment. Emre Gorgun, senior author. Thank you for all the comments. I absolutely agree. And I asked the same question about the CUSUM analysis. I agree, but I think Dr. Orich also explained that it stays up, you know, and stays there. And so that's a little bit tricky to grasp, but that shows the learning curve of the surgeon. In terms of bedside assistance, I agree, laparoscopy is good, but that's a reality. Robotic surgery is in our lives, and it's going to continue to grow, and we can't fight it. There's, you know, their patent is expired. There's 20, 30 more companies now, and then it's going to be more part of our surgical lives. With bedside assistant licenses, practitioners, actually, we can increase the reimbursement for our organizations. Like that robot assist we use, and that increases like 20% or so. I don't exactly know the percentage, but like almost like a co-surgeon. So we can bill for them and grab more money for our organization other than the surgical tech. And we need those people because surgical tech is good, but one person is not enough because they need to load the clips, you know, load the staples and things like that. But there's someone still at the bedside, not occupied with the surgical operating table, but at the bedside really actively assisting because that person is needed. Dedicated bedside assistance is important because sometimes we get thrown these interns or really inexperienced people at the bedside, and we are not at the bedside. Sometimes trocar get dislodged, or you know, there's this heavy bleeding, like you ligating around IMA, splenic flexure, and they are not experienced enough to handle these problems. So this paper is really designed to bring up the attention to readers and the surgical field that this bedside assistance is there for a reason and can really help. And in a quantitative way, we try to prove that it's beneficial, but I think more studies will follow. But thank you for your time.
All right, thank you.
I would like to.
I'm sorry, we have to move on to the next paper.
Our next paper is about techniques for sigmoid volvulus, presented by Dr. Van Zuiden. I'm sorry if I butchered that. Zweden. This is also a paper that's up for an award.
All right. Good morning, everyone. My name is Daniel. I'm one of the third-year surgery residents at WMed. And today I'll be presenting a paper looking at Hartmann's procedure versus anastomosis with a proximal diversion for a sigmoid colonic volvulus. I have no disclosures. So sigmoid volvulus is the third most common cause of large bowel obstruction in the U.S. after colon cancer and diverticulitis. However, it's more common in developing countries in an equatorial region known as the volvulus belt. So when you look at sigmoid volvulus with gangrenous bowel, gross contamination, perforation, there is kind of 3 operative interventions that we can choose from. Either resection, anastomosis, we can do anastomosis with proximal diversion, and then colostomy, otherwise known as Hartmann's procedure. Currently, Hartman's procedure is seen as the gold standard. It's traditionally viewed as safer, especially with respect to 30-day outcomes. However, especially when we look at diverticulitis, anastomosis with proximal diversion is kind of taken off as a new thing that may have a decreased long-term complications past that 30-day window. So this is a comparative study looking at 30-day outcomes for resection and proximal anastomosis and diversion versus Hartman's procedure. Our hypothesis being that Hartman procedure is superior. So it's a retrospective review. We use the ACS NSQIP database. Looked at people with ICD-10 code of sigmoid volvulus, and then looked at their CPT codes who underwent Hartman's procedure and who underwent anastomosis with proximal diversion. And then we also use propensity score matching to balance the sample size as well as their baseline covariates, the most important ones being their demographics, comorbidities, and other preoperative data that I'll present in a second here. And then our outcomes, we looked at the 30-day morbidity, mortality, operative time, length of stay, reoperation, readmission, amongst other things again. So this is a little graph of how we selected our patients. So we looked at the ICD-10 codes for volvulus, narrowed that down to sigmoid. And then you can see the CPT codes that we use there for diversion, as well as the CPT codes we use for Hartman's. So our CPT code 44146 and then 44208, they're the same, except for the second one is the laparoscopic version of that procedure. So this is our results before propensity score matching. We had 1,400 patients in the Hartman's procedure group, and then 57 patients in the anastomosis with proximal diversion for people with sigmoid volvulus again. We looked at their standardized mean difference there, and it's a slightly better measure than a p-value when you're looking at propensity score matching there. So I've highlighted for the 4 groups in bold there. And again, this is not the comprehensive exhaustive list. It would be too much for this slide. But I did want to point out that people who undergo Hartman's procedure are more likely to be male. They're more likely to be a current smoker, more likely to have chronic use of steroids, and more likely to present in septic or septic shock. And I think that last one is fairly self-explanatory. After we do a propensity score matching, we take, all the people from the RS-PADI group, and then we take the 57 people from the Hartman's procedure group that most closely match these people with respect to how they present, if they're in sepsis or not. And you can see that our standardized mean difference drops to almost 0 for all of these, except for the chronic use of steroids. So even when we, try and select for the people with the most close similarities, we still see that a lot more are on steroids who undergo Hartman's procedure. And so then after we do the matching and compare everyone, this is our outcomes. You can see that there are essentially no difference between each of these 57 patients in each group with respect to all serious complications, no difference in overall morbidity, mortality, unplanned reoperation, readmission, and operative time as well. Secondary results that we also looked at, and I won't bother to read all of these off. However, the only difference that we could find was with wound disruption. Patients who did have a Hartman's procedure were more likely to have wound disruption. So just want to address some limitations of this paper. So we do attempt to control by the degree of contamination, how they present, if there's gross perforation, feculent peritonitis. We attempt to control for that by propensity matching, trying to balance people who present with sepsis. However, the fact remains that, surgeons are they'd be more likely to choose the Hartman's procedure if there's heavy contamination or an unstable patient. The ACS NSQIP database also does not address every single factor. I know some patients are going to undergo detorsion and have this operation on a more elective basis. Other patients may have an open abdomen and return to the OR at a later time. They may be more stable and more likely to undergo anastomosis with proximal diversion. So there's still potential for unobservable bias. And then also we do have a smaller sample size as well. So to conclude, in this study, we see that primary anastomosis and proximal diversion has a similar 30-day postoperative outcomes compared to Hartman's procedure, unable to prove our hypothesis there, unable to show that Hartman's procedure was superior. So given the decreased morbidity of subsequent loop ileostomy takedown compared to the increased morbidity with a Hartman's reversal, we should be giving this procedure stronger consideration at time of index operation for the consideration for the management of acute sigmoid volvulus. And again, obviously, if someone has, feculent peritonitis, I think most surgeons would be loath to choose that option. But this is kind of a hot topic when we talk about diverticulitis, proximal diversion. A lot more people are doing this now. So that was kind of the jumping off point for this study is, should we be looking at this? And I think that in conclusion, we should be giving the stronger consideration for sigmoid volvulus with gangrenous bowel as well. I'd like to thank MSA, and I'll open the floor for any questions.
Our invited discussant, Dr. Valente.
Thank you. Thank you for the invitation to discuss. Michael Valente from the Cleveland Clinic Colorectal Surgery. I enjoyed reading your manuscript and listening to your presentation today. 12-year retrospective review, NSQIP data looking at sigmoid volvulus, the excluded cecal volvulus. Thank you for that. There's been a growing body of evidence with diverticulous literature, as you mentioned, talking about doing more, less Hartmann's procedures, less colostomies due to the morbidity and mortality of reversing those in the future. Many of those don't get reversed, as you mentioned. And this paper looked at doing the similar with volvulus. Now, and I think your point at the end is very clear and important. I think a primary anastomosis with or without diverting loop ileostomy in these emergent or urgent settings should be considered in certain clinical situations. As you mentioned, though, your limitation slide mentioned, that a lot of the surgeons, there's sepsis contamination. Those aren't limitations. When the patient's sick, that is absolutely the right thing to do. So I think that's important to get in your manuscript across. This should be considered, but in the right clinical situation. So a couple of questions. You kind of mentioned it, the status of the surgery. You said gangrenous now, but were these emergent? Were these semi-urgent? Were these elective? Do we know how many of these patients had some sort of intervention and then they were brought to the operating room a day or two later? Or were these all coming from, emergency room, they had dead bowel, et cetera? Number one. Number two is there any data in the NSQIP with the level of contamination, meaning that do we have the wound classifications at all, just to give like a surrogate of what the conditions were? Was this gross, fecal, akin to a Hinchey 4 type of situation for diverticulitis? Was this, gross fecal contamination? Was it just a volvulized segment, got them to the OR quick? That's a perfect situation for a primary anastomosis versus, stool everywhere. And then you talked about sepsis. Is there any other, looking back, no way to look at the operative report for, stability of the patient to look at more situation going back with the wound classifications, et cetera? And you did talk about in the manuscript that there was an increased readmission rate for the diverted patients. Any reason why those patients were admitted more often after they had a stoma? But once again, good job, and looking forward to seeing this in publication in the future. Thank you.
Thank you, Dr. Valente. Appreciate those comments. Yeah, so going back to whether or not these are elective, so with ICD-10 code and the NSQIP database, there's not really a great way to tell which of these were elective and which of these were more emergent, aside from their baseline covariate characteristics such as sepsis. And again, that's what we tried to balance for with the propensity score matching. And that's kind of the way we got around that, or tried to, get people who were equivalent in both categories. With regards to the level of contamination and what wound class they are, I do believe that is included in the ACS NSQIP database. However, I didn't include it on the slides just because I didn't want to make them too busy. But I will have to go back and look at my paper if it's not included, and if it's available, that would definitely be something to add for sure. And again, with regards to the stability of the patient, it kind of goes back to the first question about who is elective and who is not. And yeah, that's kind of, what we're trying to look at with, who's on steroids, who's septic. But other than that, there's not a great way to tell who is stable, more stable or less stable. Definitely a limitation of the paper. And then I'm sorry, what was it? Yeah, so again, I don't have a great explanation for that, other than the fact that we know that patients who are, getting a diverting loop ileostomy are more likely to be readmitted for problems with dehydration. That's like a known complication, is my understanding of ileostomies. And so I would be suspicious and point to that as the cause.
And what I would do for the manuscript is, can you take a look at those patients longitudinally, the ones that are diverted, and what were their outcome? Were they reversed? That would make it a much stronger paper, I think, in my opinion. Like, these people had reversal versus not, and
Yeah,
just something to look at, okay?
thank you. Thank you for those comments.
For the sake of time, although we enjoy robust discussions, so we're going to move on. Thank you for a good start.
All right, everyone, as the president of the Midwest, it's a great honor and pleasure to be able to help shape the meeting and to be able to invite speakers to come to this meeting. And I think you'll